In this episode, I host a dialogue between Dr. Chencho Dorji, Bhutan's first psychiatrist, and the Professor of Psychiatry at Khesar Gyalpo University of Medical Sciences, and Dr. Caroline Van Damme, an adult psychiatrist and family and systemic psychotherapist specializing in chronic psychotic disorders. Doctors Dorji and Van Damme dialogue about their experiences as psychiatrists in very different countries, Bhutan and Belgium. They compare their experiences treating religious psychosis, in which patients believe they are Jesus or Padmasambhava, address mental health stigma, and examine the interaction of supernatural beliefs, such as spirit possession, with modern psychiatry. The doctors discuss the emerging mental health laws in Bhutan, including forced treatment laws and pressures from pharmaceutical companies. The doctors also consider the pros and cons of religion to both society and the individual, examine 3 levels of Bhutanese Buddhism, and reflect on the dire consequences of the death of Christianity in Europe. So without further ado, Dr. Chencho Dorji and Dr. Caroline Van Damme. Doctors Chencho Dorji and Caroline Van Damme, welcome to the podcast. Well, I'm so delighted to be talking with both of you. We've had several, between us all, interviews individually about your work as psychiatrists, Dr. Chencho Dorji in Bhutan and Dr. Caroline in Belgium. And now we are coming together to have a dialogue, and I'm very excited about this indeed. I think to begin with, perhaps to set the scene, I'd like to ask you both, how did you meet? This isn't the first time you've met this dialogue, and I'm curious, how did you meet, and what has been the context of that meeting?
Maybe I'll start answering that question. First thing, before I even met Dr. Chencho, I had heard about him, I had read about him, and I had seen a long time ago a documentary about him on television. I think I was in maternity leave and I was bored in the day because my son was sleeping, and I saw this documentary in the middle of the day and I was like, oh wow, that's amazing. First psychiatrist in Bhutan. That must be so interesting to have to be pioneering mental health in Bhutan. And I was thinking maybe I should go and join him and help him, but then how do I get to contact him? It was before we had our smartphones and social media. There was internet, but there was no. So yeah, it was a long time ago, and so I just knew he existed, and I was very fascinated by the idea that a country like Bhutan had its first psychiatrist. And then I forgot about you, Dr. Chencho, but then. When was it? 1.5 years ago or something like that. I was invited at the Vajrayana International Conference in Bhutan to come and speak on mental health and Dharma practice. And Dr. Chencho was in the room and he was there in the audience. And so after my talk, he came to me and we started to talk. We didn't have much time at that moment because, we were both busy doing other things too, but we exchanged our email address and our phone numbers. And then we stayed in touch. And a few months later, I think it was about April 2023, Dr. Chencho came to Europe for a WHO conference. I think it was in Switzerland, right? And then I invited him and also another psychiatrist, Camille Noël, who I met thanks to him. He told me, there is another psychiatrist in the West. I think she's also from Belgium, and it would be nice you meet her and you get in touch with her. And actually we did, and it's really funny because she works around the corner from me. We both work in Brussels, very close to each other, and we became very good friends thanks to Dr. Chencho. So I had to go to Bhutan to meet a colleague from around the corner. And so we invited Dr. Chencho and his wife to come to Belgium, and they visited both our hospitals and stayed at our place. And then we really got along, and we became friends, I think. And it was really, really nice time, too short. And And yeah, that's how we started to get to know each other. I don't know if there's anything to add.
You want to hear my part of the story? Maybe just...
Yeah.
Well, I first met Dr. Camille, Dr. Caroline's colleague in Brussels. Dr. Caroline mentioned about Camille. She's a child psychiatrist. So we were attending a World Psychiatric Congress in Bangkok in August of 2022. 2022. Yes, I think so. And Camille got in touch with me because she was interested in Vajrayana Buddhism, and she was interested to visit Bhutan, and she was also following some Dzogchen teachings. So we kept in touch, and then when Dr. Caroline attended the Vajrayana conference in Thimphu in Bhutan, and I got to attend her session, so I just got in touch with Caroline, and I asked her if you know Camille. And that's how they got to know each other. And interestingly, Dr. Caroline told me she works in a night hospital. I was very sort of enthused with that idea. And I began to understand it. Okay, why night hospital? Because I think in English translation, it becomes night hospital, but I think it may mean something in Flemish or in French. But then I got the essence of it. By night hospital, she meant her clients can actually come to a hospital in the night, and during the daytime, they are free to do work or do whatever they have to do. But then they come to the hospital as part like a home. So that was a very interesting concept for me, to know that you have something like this in Brussels. And I was interested to come to Brussels and physically inspect this night hospital. And thanks to Dr. Caroline, she invited me and my wife there, and I visited her hospital. And I met her colleagues and also some of the staff and also the clients there. And it was a lovely hospital there, and something like which I always dreamed about. And I could, when I visited her hospital in Brussels, I knew that, yes, somewhere in the world, something like this does exist. And I would certainly would like to do something like this before I completely retire from my psychiatric work. Hopefully, something like this might come in Bhutan, not in the exact form and shape, but on similar themes, on similar principles, on similar sort of approach. So I was really amazed by things that I saw in Brussels. So yeah, after that, then we were in touch in most of other things, and I later realized that Dr. Caroline also is interested in Sowa Rigpa and other traditions, and I had similar interest as well. So I think we share a lot of common ground. And so nice to meet you and Camille and be able to again talk today.
Yeah, it's really nice. It's really nice. And yes, we do share very similar visions. I think both of us, we want to use whatever works to help our patients, right? Be it Western science, the scientific model, there are really good things that work there. And as a psychiatrist, of course, we practice both of us that, but then there's also the belief systems of our patients and what works for them and what they believe in, and how we try to find ways where we can also be helpful for them with that. And as you say that our night hospital, we really try to be as much adapted to what's needed for the patients, what are the patients' needs. And of course, if we want to transfer that model to another place, to another country, there are different belief systems in different countries, and so it's never going to be exactly the same. But the ideas behind it, like one of the ideas that we have is we don't have the objective to cure our patients. We want them to feel, to have a good quality of life. Actually, that's really the objective. And if they are weird or bizarre or strange, well, and they are happy like that and they don't harm anyone like that, then that's fine for us. And so, for example, one of the examples we have is that we have quite some patients, quite some patients. Sometimes we have patients who will in the summer walk around with very thick clothes, like very thick winter clothes, and it's really hot. It's like July and it's really hot outside, and they walk around with winter clothes. So we could say, oh, that's not normal. They should wear t-shirts and shorts or whatever, and wear adapted clothes. And so it's strange to see someone walk around in winter clothes and a hat and winter hat, and it's actually because for that patient, feeling the sweat helps that patient feel the limits of his body. And so for him, it's necessary because it's scary not to feel the limits of the body, because some patients have a difficulty to find out when does my body stop and when does my non-body start. And so sweating helps them to feel the limits of their body. And so for them, it's helpful. So we will never do anything to make them take their clothes away, because that's how they can manage to function quite normally and fine for them. And so there are many, our patients in the neighborhood, they are quite strange. And so I think there's still a lot of work we should do about stigma, because there are a lot of prejudices about people suffering from psychosis. But we don't want to make them, the perfect average citizen. We just want to help them have a good quality of life. And if they hear voices and those voices are not too difficult for them to live with, and they can live with it, and they can find a way to cope with them, then it's okay. Then I'm not going to raise the medication and increase the side effects. And so I think that's what I love about working in Brussels. And so if there are patients who have different traditions, who have different belief systems, well, I'll try to use those two to find ways to help them. And I think Dr. Chencho also has this vision on helping people with mental health issues.
Yeah, I mean, the challenges of mental health, as I see it, whether you're in a Western advanced country or in a far-flung remote country like Bhutan, I think there are enormous challenges in both worlds that I see it. Because psychiatry is still, I think in the Western world, of course, Dr. Caroline will add to what I just have to say. But in our part of the world, of course, lack of knowledge of mental disorders is the number one challenge. The stigma and the taboo and the shame is quite another. Even I was telling Steve in our other conversation that even our medical fraternity, our medical community perhaps has the biggest stigma related to mental disorders. Now, I also see this challenge. Mental disorders diagnosis is very peculiar in medicine because you need an individual skill to be first able to get a good history and then to be able to elicit those psychopathology. And if you don't have a good skill, you are going to muddle up the case because so many compounders will come in between and you will be having a very bumpy ride. And then you'll mess up with the case. I find this as a big challenge in Bhutan as I teach the younger colleagues in Bhutan. I tell them that a patient is admitted this time. Can you go back to the last admission the patient was there? Can you revisit the whole history and your findings? And again, now see what is the change, what is same, what is different. Review your diagnosis. Because if you can't make a good diagnosis, the whole approach, the whole perspective or rather your plan of a management will go haywire. I think that's the biggest challenge. But if you are skilled enough and you know what you're doing, I also think that psychiatry is a very, what do you call as a very simple science, because we don't need this high-tech state-of-art technologies to diagnose psychiatric problems. All I need is a skilled doctor to diagnose the problem, and you need few tools, maybe some counseling tools, or even a bag of antipsychotic and mood stabilizers. You can treat a psychotic patient on top of the mountain. You don't have to bring this person in the hospital and subject to all these MRI and CT scans and blood tests. I can very well go up to the mountain, diagnose the case, and treat it. So psychiatry can be that simple as well, but it can also be so difficult. I mean, I can imagine the pressure that Dr. Caroline and your colleagues may be going through. Especially what I see in the West is the monopolization by the pharmaceutical drug companies. They are after drugs. I mean, I was in Australia and I was in Johns Hopkins, and I could see the pressure that the doctors there go through every day. They're literally fed by these pharmaceutical companies to prescribe their drugs. So sometimes I find that places like Bhutan, where we don't have pharmaceutical companies, where we don't have those representations, at least they let us practice in peace, and we do whatever we like. But of course, we have very limited access to those drugs that you have in the West, and we have to deal with a combination of one or two antipsychotic drugs or mood stabilizers. So challenges are there in both worlds, and I would also like to hear from Dr. Caroline, how you see those pressures, especially from the modern pharmaceutical companies going after doctors and basically feeding them with that. Just before I finish up here, in the last 1 month in my ward, I come across some 5-6 young adults in the age range of 20 to 30 who have been psychotic. And some of them were in and out of the jail, but some of them were just left in the houses, just lying, idling around. And the families, they did not probably suspect they have mental disorders. If they did suspect, they did not bring them for treatment. I mean, even when I have been practicing in Bhutan for the past 25 years, there are still so many pockets in Bhutan. Even in Thimphu, the state capital, I see 2 of the young people who have been lying in their houses for 3 years, just eating and sleeping and really not doing anything. And if at all, some of them did some odd things here and there, but they did not come to take treatment from us. So I think we have this huge gap in our part of the world where a lot of the people are not coming and receiving treatment because we are not able to reach out to them. So maybe I will ask Dr. Caroline this perspective on this pharmaceutical, the pressure from the pharmaceutical companies.
Yeah, well, I think you raised up several topics which are, which you say in your part of the world, but unfortunately, still today, ignorance about mental health and stigma is still very much prevalent. And when I say about trying to raise awareness in the neighborhoods, I'm not talking only about that. I'm talking about in general, people just have no idea. They have lots of prejudices. It's a very taboo subject. When I started as a medical student, when I started my first wards in psychiatry, I had a patient who was older, and since he had been hospitalized like forever in a mental health institution, and his family, since he was hospitalized, he never had his family visit him anymore because there was this idea that he brings bad luck. And the poor guy was all alone in this, with no contact with anyone, without anyone from the family. So in not such a long time ago, it was, we would put people in mental health institutions outside of the city, in the countryside, where there's no one to see them, hidden from society, and they were just, they were just put there, what we call the asylums. And they would stay there forever, their whole life, and no one would take care of them anymore, because there was this idea of those people are dangerous, they are scary, and they bring bad luck, and so it's better not to talk about them and not to take care of them anymore. And even when I was doing my clinical rotations and in all the different specialties, and when people would ask me, what do you want to do when you finish your medical school? What specialty do you want to go into? Sometimes I wouldn't dare to answer. So there was some self-stigma, some self-censorship, or I would say that I was interested in maybe doing psychiatry, although I was sure I wanted to do that. And then they would answer me, okay, give me a real medical specialty, because that's not a real specialty. Psychiatry is not a real specialty. So as you're saying, still today in the medical profession, there is a huge stigma on mental health. And what's even more terrible, I think, is the medical profession. We are, we receive teachings on mental health, all of us. Many of us do clinical rotations in psychiatry, and still people with mental health issues, when they go to the emergency room for physical problems, because of course they have physical issues even more than people who don't suffer from mental health issues, they don't get the treatment they deserve, because there is this stigma about mental health, and so they hear, oh, it's all in your head. Oh, it's this and that. And I have had several cases of patients where I had to call back the ER doctor and say, now you see this patient again, because you should check this and this and this. And then it appears that the patient was in life danger, and it should have been seen, and it was not. So I think that's terrible. And I think there's a lot of work to do in the medical profession still today about stigma. So maybe I hope with the COVID pandemic, there is more awareness on mental health, finally. But it's also, so that's one thing. And then about your question on, sorry, I keep receiving notifications.
Pharmaceutical companies.
The pressure of the pharmaceutical companies. Well, the good thing here in Belgium is that there are some laws which kind of protect us from the pressure from pharmaceutical companies. So they do visit us. But for example, doctors are not allowed to have shares in pharmaceutical companies. That's already one thing. So I'm not allowed to have shares in pharmaceutical companies to keep our independence from them. So we are really not allowed. And then when there is research and we publish articles, if it has been sponsored by pharmaceutical companies, we always have to say it, and so to mention that. And so, of course, some research that has been done by an independent institution, I will pay much more attention to it than to some research, some article that was sponsored by the pharmaceutical company. So there are some things where they can't really put pressure on us. And the other thing is, I know, for example, in the States, pharmaceutical companies, they know which doctor prescribe what. And with us, they only can know in the region where there is a group of doctors, they just know the average that's being prescribed by those doctors, but they don't know which doctor does what or prescribes what. And so they don't have access to that information. So they can't come and personally pressure us to prescribe medication. And So, and then they are also in the past, they would sponsor travels, you know. I've heard colleagues going to Greenland or doing nice trips in the past, sponsored by pharmaceutical companies. And now it's not allowed anymore. So pharmaceutical companies cannot do that anymore. So I don't receive paid trips to go and visit nice places. Yeah, they had nice experiences because they could travel around the world for free, but it's not very deontological. And so at least here in Belgium, those things are not allowed anymore. So there has been some insights in that there was too much influence from the pharmaceutical companies. And now this influence is much reduced compared to, let's say, 20 years ago, something like that. So that's a good news. What else could I say? And so there is
the other issue I wanted to discuss with you, Dr. Caroline,
yes,
is on the Mental Health Act or law. Now, in Bhutan, we have not yet have a mental health law. I personally did not want to push for a mental health law because the Bhutan Penal Code has one clause which says if a person has committed a crime under the influence of some sort of insanity, then the person should be treated rather than being incarcerated in jail. That's only one aspect. I thought that was enough for me to hold on to my patient's rights. If I push for a mental law, our parliamentarians would have very much liked to enact, because our first parliament enacted 52 laws in 5 years. Now, because the democracy is so young and so new to Bhutan, and the parliamentarians thought that their job is to enact laws. So they kept on enacting laws. And then we realized that these people have not thought through things. They just got all the ideas from here and there. When they deliberated on those acts and laws, they did not really think about how to implement those laws on the ground. That needs resources, human resources, other resources to implement laws. It's just not having a law enacted in the parliament, but once it becomes an act, it has to be implemented on the ground. I was very scared that if I push for one, I might get one. But in the end, I will end up implementing the laws on the ground without much resources, whether it's human resources or finances or what. And I really didn't push for that. And one good thing with that is we have the freedom or the leeway to negotiate with the patient and the families for so-called involuntary treatments, So we don't have, the law is not so rigid that our hands are tied. We always have some leeway of negotiating with the patient or their families. And then, because otherwise, if the state has to do it, who are the state actors? It's me and my few colleagues. And our hands are tied. And so I've never pushed for a mental law. I understand. And when I worked in Australia and the US, they have those laws. And especially in Australia, they have the so-called guardianship boards, where it's like a kangaroo court, where a church, along with the community representative and a psychiatrist, three-panel board, called a guardianship board, will actually visit various hospitals, psychiatric wards, and then determine whether somebody has to be put on involuntary treatment, especially those people who have chronic psychosis or psychosis, who do not have insight and who do not want treatment or who do not believe they need treatment. But then the law protects them, because law says that if a certified professional, a competent professional certifies that somebody is having a psychotic disorder, but he does not believe he has the illness, then I think he needs to be protected or he needs to be treated somehow. I mean, how do you, I mean, I just want to ask your experience with implementing those laws in your context, Dr. Caroline.
Well, there is a whole history, it's a whole topic on itself, because in the past, people with mental health problems and who were, who were maybe being a danger to themselves or to society, it was the mayor of the city, along with the family and the doctor, who would decide for forced treatment, and they were then put in asylums or psychiatric hospitals, and it could be there forever. And it was the doctor who would decide about how long the patient would stay there. And so there has been some abuses with that, and that's also, I think, one of the reasons why there is such a stigma around mental health. Like, those people are dangerous, but also on the other side, if you end up in a mental health institution, you're at the mercy of the doctor, and he has all the power, which is true. It's not very healthy. And if the mayor of the city is related to the patient because it's his son or whatever, then you can really, I have met an older woman who, as a young girl, because she was falling in love with the wrong guy from the wrong family, her family had been talking to the psychiatrist and to the mayor, and they had been able to put her for involuntary treatment in a psychiatric hospital. And she stayed there for many years. She received electroshock therapy. She received all kinds of medications. And this woman, because it's her brothers and sisters who told me that, she didn't have any problem to begin with. But because she was dating the wrong guy, the family would put her away in psychiatry. And so because of that, the lawmakers started to think about it. And in 93 or 94, they made new laws, and those are the actual laws that we have in Belgium. So every country has their own regulations. I know in France, it's still the mayor who has some say in it. In Belgium, it's not. So what happens is you either already committed a crime, and then it's part of you get incarcerated, and the justice says, okay, you were not responsible for your act, because you were suffering from mental health problems, but you did commit a crime. And so then you are put in a forensic psychiatry unit. So you receive treatment. You are not considered responsible for your act. So you did commit a crime, but you are not, they say you are not guilty really of that crime. So you need treatment, and if you are still dangerous for society, you need to stay in that forensic unit as long as the danger is there. So those people are the forensic patients, let's say. And then there are the ones who did not commit a crime, but who are at risk to harm someone else or to harm themselves, to commit suicide. And if that's the case, then a psychiatrist like me, or in fact, any doctor, that's the law, but the doctor should not be related to the patient. It should not be your family member. We should make up a report. And then depending on the urgency of the situation, if it's not urgent, it goes to a judge. And if it's urgent, it goes to the prosecutor. And the prosecutor is always a prosecutor on call. So then we call the prosecutor and we say, okay, this patient is in imminent danger to someone else. And then the prosecutor decides to put him in a mental health institution. And so either the prosecutor or the judge, because if it's with the prosecutor, a few days later, the judge comes and evaluates the situation, and the patient can take a lawyer. and the psychiatrist of that hospital comes too. So I can never put one of my patients in my own hospital by force. If I start a procedure, he's going to be sent to another institution, so as to not that I fill my beds and earn money on that. So that's the idea behind it, so that it's as independent as possible. And then the patient is sent there, and then it starts for 40 days. But the judge can also decide to stop the measure if he sees that the conditions are not met. And then after 40 days, the psychiatrist has to reevaluate the situation, ask to prolong the measure if necessary, and if not necessary, he stops it. But it can also mean that the patient does not have to stay in the hospital. He can also go home and receive mandatory treatment. So I follow several patients who are under mandatory treatment. So the judge forced them to get treatment, but they are not hospitalized anymore. And so they just have to come to my consultation, take medication. And if they stop doing that, I can call the hospital that's responsible for that patient and ask them to reintegrate them in the hospital, in the ward. Or if I see that he's getting into a psychotic state again, and the danger is coming back, then I ask them to be reintegrated for the time needed in the hospital. And so I think that's this system has its issues. It's not perfect because we have to evaluate in a short time, especially if we don't know the patient very well. Sometimes a short amount of time is too short, and I think we should have a longer evaluation period of, like, let's say 2 days or something, that we have, more ideas about how the patient is doing. But still, the fact that it's decided by independent people who are even not doctors, it's the justice system, so that the justice system sees that there are no abuses coming from there, and that patients don't stay longer than needed in the hospital. And there needs to be a danger criteria. If the patient is completely in psychotic state, but is absolutely harmless, and there is absolutely no risk of danger, then we are not allowed to force him into treatment, because the idea is that people should always decide by themselves if they want treatment or not. So that's how the system works in Belgium. And I know in many countries it's different, but we decided to have the justice system make the end decision. It's easier for us too, because sometimes patients, as you say, they don't have insight in their illness, and they are angry that they have to receive mandatory treatment. And I can say, well, it was not my decision, it was the judge's decision. And now we have to follow the judge's decision because that's the law. And I think that's that makes it that the anger doesn't come on me, but goes on the judge, and he sees the judge like one time, maybe 2 or 3, but not so often. And so, and this idea that you can come, when you come to the judge, you receive a lawyer that protects your interest. And so if patients cannot afford a lawyer, they receive a free lawyer, I don't know, Prodeo lawyer, but they always have a lawyer. And the Prodeo lawyer or the normal lawyer, they are not allowed to give, to contradict medical information. So if the doctor says there is psychosis and because of that there is danger, the lawyer cannot say, I don't agree with that, because he's not a doctor. But the lawyer has to see that the interests of his patients are met. And so he can say, well, yeah, that doctor is actually an uncle of my patients, or, he has to find out, or the conditions were not completely right. And so usually we don't have many difficulties with the lawyers, because they just have to see that the law is followed and the patient's interests are followed. And sometimes the patient's interest, the lawyers see themselves that it's better for the patient to be hospitalized. So
I can see one of the complications of having a mental health law in Bhutan is not just the patient who believes in supernatural causes of illnesses. The family believes, the culture, the community believes sometimes that deities and supernatural forces have possessed the person, and they they're acting in a way because of that supernatural power. In that case, there's another reason why I was not pushing for an act, because then I would say, okay, the person is psychotic, obviously psychotic, or even manic. But then the culture, the community, or the family do not agree with me. They believe that, yes, is some supernatural causes. The patient should not be taken to the hospital, but rather they have to do some sort of rituals to either get rid of the deity or the ghost or the spirits or the supernatural causes. So there can be another sort of a clash of ideas. And I think that's one reason I was not, again, particularly pushing for an act which might say any psychotic patient who doesn't have an insight mandatorily has to be given treatment in a psychiatric hospital. For one, we don't have many psychiatric hospitals in Bhutan. We have only one in Thimphu, and that's again a 20-bed ward. We have beds in all hospitals, but they are not per se psychiatric specialist center. The other is, if the family doesn't believe the person is psychotic, if the community doesn't believe, then I think becomes a big challenge for us. But on the other hand, I also know when some of our monks become sick or ill, or even some of the Hindu sadhus, we have some of them, they become sick. By the time they come to us, they have done a lot of the so-called rituals and their own determination or divinations practices they have done. And then the family and the community then decides, okay, now I think we have done enough of our traditional stuff. This is going a little beyond what we would normally call a range of, it doesn't now fit. I think that now it has to go to the psychiatrist. So by the time they come to us, our work is much easier, because then we don't have to tell you you're a psychotic, because the family has brought the person and probably the community has already endorsed that this is going a little beyond what normally our people would experience. So then we can just treat them, But in our setup, families are the background. We don't have social services. And we don't have much community so-called volunteers or workers. So getting the families on our side is the biggest challenge. And when we do get their support, things are much better. I always tell them, I know you have tried so many things on your own so far, and nothing seemed to have worked. But this time, we'll do it together. You and I will do it together a little differently. Maybe I have some ideas that you probably never even imagined or even thought of. And I have some of these tools like medicines. So maybe this time, maybe we'll work together and see if the results are different. But chronic psychosis, one of the biggest problems with chronic psychosis is what you call as negative symptoms.
Yeah.
There's something called positive symptoms and negative symptoms. The positive symptoms are when people are deluded, they have hallucinations, and they are reacting or responding to those hallucinations and delusions. The negative symptoms are not obvious. Negative means a person doesn't talk, doesn't look after himself, doesn't like to socialize, doesn't want to get up from the bed, doesn't like to dress or groom himself. Those negative symptoms are more difficult to treat and also more difficult to identify, especially for the families. They do not believe that this is a symptom of chronic psychosis. So again, this is something very difficult for us to identify, as well as to teach to our students, and also to teach to the families why a disease called schizophrenia can cause these negative, so-called negative symptoms. which makes the person very, very disabled. I think so. The challenges of, really communicating this to families, to the communities. It's even more challenging. Yeah, really.
Yeah, exactly. But it's exactly the same here. There is so often where families also don't believe in psychiatry and don't believe in medication and getting help. And people here also believe in, problems with spirits or energies, or I hear all kinds of explanations. So I never, it's always much more a challenge if we cannot collaborate with the families because they feel threatened by us. And it's also, I think, a sort of protection, like, who are you to know better than us? We know our son or our daughter the best, and you come here as a specialist and you are going to tell us where we failed. And they feel, so they arrive on the first consultation. Usually they are very defensive, not always, but very often. It happens very, very, very often, more often than not. They are very defensive, and so my primary job is really to try to find a way to collaborate with them, because if I don't have them with me, it's going to be so much more challenging. And because we do have patients who follow our advice, who take their medication, and then they are discharged and they come back to their families. The family tells them to just stop that medication. That's not helping you. It's going to make you brain dead and this and that. And then they stop the medication and hop, it starts again. And so if we don't have long-term collaboration with the families, it's so much more complicated. And so here it's exactly the same challenge. And so when people come with all their beliefs, I tell them, because sometimes, sometimes there are also family tensions, and psychosis is in some cultures is more accepted than depression, for example, or in Northern African cultures like Morocco, we have lots of Moroccans here in Belgium. It's much harder to say you are depressed, but to say that you are in contact with the jinns and the spirits and the spirit world and this and that, and have like sort of crazy behavior is more culturally accepted than to say I'm depressed. So sometimes we also see those symptoms come up like that. And so it takes a lot of work. And so I'll never try to contradict people, because who am I to know? I have no idea if it's jinns or if it's spirits or whatever, or energies. And so I always say the definition of psychosis is just a set of things that we see, but we don't know why it's there. So I'm not going to judge on the reason why this psychosis is there. But as I see it now, things are complicated. Your son or daughter threatens to kill you, because sometimes it happens that psychotic patients want to kill their parents. And really, I have had several patients who tried to kill their parents in a psychotic episode with a knife, and, run after the mother and try to kill her or something. So I say to the parents, that happened a few days ago. So now, if we don't want this to happen, even if it's energies or whatever, I can help you to help you together. There is medication which can reduce what's going on. And I don't know why this medication works, because it's all hypothesis. It's the dopamine hypothesis, but it's a hypothesis. There is still, and so I can give some psychoeducation and explain what happens in the brain and everything, but we still don't know exactly why this medication works in a way and not in another. But by going like this and not going the discussion with it's spiritual or it's medical, and just saying, okay, let's help with, and if you have some healers which can help too, then let's do it. Let's have the healer, but let's also let's take everything that can help, all the tools to help these patients. But then, as you say, also these negative symptoms, that's the biggest issue, because medication doesn't work against negative symptoms, even if some what do you say, pharmaceutical companies, they pretend that their medication is efficient against negative symptoms. I don't really see that. Sometimes they can make negative symptoms worse, but improve negative symptoms, I haven't seen that yet. And that's a very big challenge. And then add to that also the problem with the drugs. Cannabis, for example, also increases the positive symptoms, but the negative symptoms, we even call it the amotivational syndrome. So those patients are completely flat with no energy, and that's also that's also a problem, because many people don't see the fact that cannabis increases the risk of psychosis and makes it worse, and they think, oh, it's a medicinal plant.
Karen, did you know that cannabis grows wildly in all parts of Bhutan?
Yeah.
And probably we may have some 30-40 species of cannabis. And in my generation, I didn't know how to smoke it. I'd never smoked it. My parents were feeding the cannabis leaves to the pigs. Those days, we used to have subsistence farming. So we had pigs and cows and everything in one place. And my parents were chopping the leaves and giving to the pigs. And it did two things. One, it increases the appetite. So the pigs have a voracious appetite. And second, after that, they sleep a lot. So they put on a lot of weight and fat, which is good for the pigs. But now the present generation of Bhutanese, the young generation, they started smoking it. And we have a lot of psychotic breakdowns because of cannabis-induced psychosis. Fortunately, most of them just recover very fast.
Yeah.
Just brief couple of weeks of just antipsychotic medication, and then you stop the cannabis. Most of them recover very fast. But of course, some people are predisposed to become chronic psychotic or schizophrenia. And then cannabis can precipitate or aggravate the condition. So yes, we are also having the pressure of the government is trying to liberalize cannabis cultivation. And so we are right now in the process of going through the motions, whether you should grow this cannabis, you should have those farms or not. Some farms are already allowed on the research basis, but we are really scared what will happen if we really go into a commercial production of cannabis in the country, because we have it all over the countryside. They're not as potent probably because they are wild, and but then nonetheless, I think they get it free day in, day out, almost 8 months in a year, and they can save a lot of the dry leaves for winter. So that's quite a menace in our society.
Yeah, but cannabis is that's also a very big subject. It's if it grows wild and it's not, manipulated, then I think most of the time it's quite harmless. But the thing is, today, at least in industrialized countries, and especially I listened to a talk by Professor Murray. He's very famous. Studying all his career, he's been studying the link between cannabis and psychosis, and so I listened to him a few months ago on the World Psychiatry Congress, and so he really says that now we make cannabis with more and more THC, and so THC is the substance that makes you psychotic. So if you inject people with pure THC, they become psychotic, all of us. And so the more we consume cannabis, and the more we are genetic risk, and the more the concentration of THC is high, which is happening. So every year the THC concentration is going up in several parts of the world, like in the UK, it's very, very bad. The more young people have first episode psychosis and get hospitalized for that. And so apparently in Canada, when they started to legalize, they have legalized cannabis. And in 10 years' time, the number of first psychotic episodes requiring hospitalization doubled. I think that's a huge number. But it's true, the good news is when you stop, then the psychosis, the prognosis is much better. But the thing is that many of those cannabis consumers, they don't want to stop. And so they continue to consume. So there is maybe not a physical addiction, but there is a mental addiction to the effects of cannabis, and they have a very hard time to stop. And so the psychosis just continues for years and years and years. And I think that's a very, very big issue because most of the people, I even didn't know it, and I'm a psychiatrist. But now we really know from research that smoking pot today is not the same as in the 60s. I think in the 60s was like now in Bhutan. So it was much more natural.
You heard of Guru Padmasambhava?
Yeah.
The Indian saint who spread Vajrayana Buddhism to Tibet. And he's believed to have visited Bhutan at least 3-4 times. He actually proscribed smoking. And they're saying that smoking is injurious to health and also it's a sin or sort of a negative karma or negative deed. I'm saying that he prescribed probably cannabis smoking, not tobacco, because I don't believe tobacco was available in the 8th century in Bhutan, because I believe tobacco came from Latin America and probably they were brought in by the Portuguese and the Dutch and the colonizers when they sailed to far-off lands and then brought them probably to Asia, maybe in the 17th century or 18th century. I think when Guru Padmasambhava visited Bhutan, I can imagine a lot of Buddhists were smoking cannabis and they were zonked out and they were lying left and right. And probably then he thought, oh my God, I think this should be banned or proscribed. So Buddhists still believe that tobacco is a sin, and Guru Padmasambhava basically proscribed tobacco. Tobacco. I'm saying probably he proscribed cannabis, not tobacco. And then, of course, some of the Buddhist masters say, no, Padmasambhava is a man who lives in 3 worlds. So he could have forecast what will happen in the 21st century. So that's why he told it in the 8th century. I'm basically a simple man who believes in what I see. So I keep on telling the Bhutanese, it's not tobacco, it is cannabis. It is cannabis. And cannabis was growing wildly those days here. I think, Dr. Caroline, we are taking the show from Steve. So let Steve get us involved.
Well, this is fascinating discussion. Thank you both. I would like to explore a couple of themes with you. I know we'd like to talk about modernization, urbanization, and those effects, and we've already begun to touch on some of that. But I'd also like to talk a bit about religion. In 2 ways. First of all, religion, its pros and cons for the individual and society regarding mental health, and also the ways in which religion interacts with mental health disorders. It's been said, I think, that religion is, we've talked about cannabis, but wasn't it Marx that said religion's the opiate of the masses? And it can give some meaning, particularly when facing suffering or difficult times. It can also give perhaps societal cohesion through shared values and ritual. But those same benefits perhaps can also be flipped, where religious beliefs can cause suffering. Both Buddhism and Christianity are fond of threatening hell, for example, and other things like that. And demons and supernatural influences, devils and so on, are common to both religions. And also the societal cohesion of religion can also, in its opposite, be fractious and can see sects against each other, even within the same overall religious umbrella. Lineages fighting and whatever the case may be. So it seems that religion is something of a double-edged sword, both at the individual level and at the level of the society. So I'm curious about that. How do you both see religion at that level, interacting with the individual in society? And also the other thing, and I'll just throw this in here, I'm curious about how religion interacts with particular mental disorders. We've been talking a lot about psychosis, and I know from both of our interviews that Dr. Caroline, among your patients, there are those that have religious psychosis of various types. They believe they're Jesus, for example. Some psychotic patients might believe they're the devil, in fact. Or sometimes I've observed believe they're Jesus and the devil both coming together in some sort of way. Anyway, the point is that there's those Christian images. And Dr. Chencho, you were saying in one of our previous interviews that you have lots of Padmasambhavas and Yeshitsugels who you encounter, people who believe in their psychotic state to be reincarnation or an emanation of important religious figures from your traditions. So I'm curious also about that, if we might compare and consider the implications of religion in terms of the actual disorders themselves. So I've given two general questions there, and I'm very interested in what you both have to say about those matters.
Well, I think, I come from a Buddhist background and the context here. We don't have many other religions in Bhutan except Hinduism and Buddhism, which share many of the tenets, such as non-violence and karma and things like that. And as I was saying during our last conversation as well, Buddhism, I see it in three levels or three ways of looking at it. One is as a religion that is really practiced by the masses in Bhutan, with all the rituals and the fear of gods and deities. And as a religion, it's also shamanism integrated into religion. So common masses believe in that. They fear God, they fear, they appease them, and just do all sort of things on a day-to-day basis. But there's also the philosophical part of Buddhism, which is the spiritual part, as a way of life, as a way of thinking and guiding your life trajectory, or sort of, how you go into those tenets. Yes, I think having a religious belief and practice is both protective, as well as it can also be, in a way, harming you as well, if you can't handle those. Protective in the sense, if you chant mantras and do rituals and things like that, you obviously get a good sense of satisfaction from doing those things. And it can also be a collectivist idea of whenever you do rituals, you actually do it in a group, in a family, in a community. So there is this collective sense of belongingness, a sense of sharing of ideas, sharing of emotions. And so that's quite protective in many ways. But the difficult part is when you start believing in those supernatural stuff, such as deities and gods and spirits and devils, that's where the problem comes, because people do suffer immensely out of fear that they are consumed by them. And some of those practitioners are not necessarily ethical. They might actually enhance the scare and make them even more so that they can manipulate these people or emotionally control these people. So it can go either ways. But as a Buddhist philosophy, I think the whole tenet of Buddhism is based on whatever we do or believe is a sort of a delusion. We are supposed to have a Buddha nature in us, but then we are deluded by what we believe, that we don't recognize our Buddha nature. So in that case, again, from a very psychiatric point of view, I think the demands of the philosophical knowledge, it's set far, far away from most beings, because they can't even think about getting rid of this delusion. and recognizing your Buddha nature and attaining enlightenment or nirvana. So for some, having a severe depression can be seen as a type of recognizing your true nature, your repentance, that whatever you do and think is wrong, that there's something very different, that you need to transform yourself from transcend those and become enlightened. So again, it's a very complex belief system. But what is important for me as a practitioner is I need to understand that all these are there, but I don't have to really deal with myself on a day-to-day basis, especially in the context of Bhutan, because I'm just one of those players. There are many, many enlightened beings. There are many, many practitioners who do all these things, say this every day, and people really chant those with them. I'm just one fellow, and I'm a good observer, but I do not necessarily challenge their belief systems. I just go along with the tide, but I also don't, I don't patronize or I don't subscribe to their belief system. I basically have a neutral stand and not really confront them in a way. But it's also important for me to understand that all these phenomena can happen and people can come with all sort of belief systems. And it's not for us to fix all those belief systems. It's just that we need to fix some of those things which goes a little out of hand. For example, if they become Padmasambhava, I allow them to be Padmasambhava for about 2 weeks in my ward. And by the third week, Padmasambhava should have been away. Otherwise, I find that I'm not doing my job. Same with the Shishogels and other beings that invade their mind every now and then. Generally, I give them about three weeks' time for them to come to the ward, settle down, and in about 3 weeks' time, the Padmasambhavas and Shishogels are not going away. Then I get a little worried that I have to do a little more dramatic things like that. But like I said, by the time they come to my ward, to my attention, whether they are believing as Padmasambhava or Ishishogel, they would have been practicing this for months on end, probably. And then the society, the community start believing that this is a little beyond what they would expect a real Padmasambhava to be. So something is not there, something is amiss. I think now we should go to the psychiatrist. The pressure for us is when they do come to us, they expect us to deliver miracles. And that is a bit of a pressure. But I have to tell them that give me about 2-3 weeks time, and then I will hopefully try to fix the problem. Don't expect me to turn somebody overnight into somebody else. I'm not a magician. It's just time, time cures people.
Yeah, it's very interesting what you're saying, because it's a little bit the same here. When you say whatever we believe is a delusion that comes really from Buddhism, I think that teaching is something that's so helpful for me when I practice psychiatry, that even my own beliefs are a delusion. So I don't judge what people are telling me when they say they hear the voice of God and they hear the voice of the devil and they are chased by God, because God is usually not nice. It's really strange. Because supposedly in Christian beliefs, God is supposed to be nice, and it's the devil who is evil. So I have patients who are chased by the devil, but there are ones who hear God, but it's usually not positive. They are scared of God, and they hear the voice of God yelling at them, and so it's really they really believe it's true. And so for me, that teaching that comes from Buddhism doesn't come from Christian belief, that whatever we believe is a delusion. I think that is so helpful when people ask me what I think of it. And then I say, who am I to have a judgment? You hear those voices, it's really true. So who am I to say, because I don't hear, the only thing I say is I don't hear them. So I don't know. So I always take an agnostic stance. I always say I have no idea what to think about this. What I do know is that I see you're suffering from all this, and let's try together to look at what we can do to reduce this suffering. And that is something where people are more prone to accept help when you don't, when you don't say, oh, that's not possible. And that you say, I don't know, because who am I? I believe certain things which other people disagree with too. So where is the truth? But there is this truth of suffering. You are suffering here, and let's together try to find solutions. That usually works quite well. And sometimes, yes, I will see if the voices get reduced, or these beliefs that they are being attacked by God or whatever is being reduced, and that means that the medication is working, so I'm happy. But then if it's not, then I start to worry too, and then I have to look at different ways of finding solutions. And sometimes patients really ask me, please find something, some medication, some pill that reduces those voices, because they are not being reduced. And then I feel really bad, because sometimes I don't find. Sometimes they are just resistant to medication. But I think there's also, while Steve was asking his questions and you were answering, I think one of the big differences between here in Europe and you in Bhutan, we used to have in Europe also a very strong religious community with very strong religious practices, and they are nearly completely disappeared. Churches are empty, there are no priests anymore, and so for many different reasons, people have turned their back to the Catholic Church. Belgium is a Catholic country, so and what makes the difference between Catholics and Protestants is, I think, Catholics have many saints. So when you go to churches, you have many statues of different saints and paintings, and it's all very impressive and amazing. And when you go to a more other Christian churches, it's much more empty and more like a Zen style, in the Catholics, I would say it's more like Tibetan Buddhism with lots of images and lots of, but so there's also has been this big anger, and people have turned their backs towards the Catholic Church for many reasons. One of the reasons is one of the major reasons is the sexual abuse that has been going on in the church for so long, and it's so widespread. And so now there is this collective, people are realizing collectively that it's really not okay, and that it's really something we have to do about as a society. So not only the church, but also outside of church, there have been a lot of sexual abuses, and so now people really start to want to do things about it, because it's very traumatizing for the victims, and they have not been protected enough. But the thing is, people have turned their back to religion, but that means that there is also the problem if there is not this collective religious practice anymore, and that is, there is like the spiritual void, and that's creating other problems and big problems, like you cannot.
That's also what I fear in Bhutan. At this stage, I think there's too much of it. But I also fear that the young generation with this IT age and AI and machine learning and all this, all this can disappear very fast from our radar. And then we are left almost like barren. Everything is sort of sanitized. And then, so I also fear that the change may come very drastically and very soon, rather than probably in a step-by-step manner. I also fear that our modern monks and practitioners are not living up to the age, and they are still bogged down with their ancient ways and means of doing things. The religion has to evolve to make sense to the new generation of youngsters. And I mean, I can then learn, I mean, I learn from what Dr. Caroline is saying, that people are turning against the churches and they are angry with them. I mean, that's very sad, because we are losing our civilization, our belief system, a way of life, a way of, I don't know. I mean, we don't want this sort of thing to happen in Bhutan. But it will come. I mean, if our monastic institutions and monks do not evolve with the evolving times, it can happen in Bhutan in the next 10, 20 years. I mean, it's not far away. And that's very sad. We don't want to lose such a rich tradition and belief systems that really protects us, that keeps people in check, that people in harmony. And then we go against that. Then we are left with what? Only the science. And I think science does not have answer for everybody. And that's where I think we are driven at. So I can sense that what you're saying is what we will also probably come across. And I think that's why people like us in Bhutan, we can learn a lot from what has happened in many countries abroad. And all advancement need not necessarily be in a nice direction. That we have to learn lessons of what not to do, or what is the best way forward.
Yeah, but it's really, I think if the religious organization is not evolving with society, then we get into trouble. And that's what's happening with Catholic Church. They are holding on to their ideas which date from hundreds of years ago, and they don't want to change with society. And so they are losing people. They are losing people, and they are so rigid. I know, for example, my great-grandmother, so my grandfather's mother, lost many babies at a young age at birth, and she lost them before they got baptized. And so she was very religious, very Catholic. I've never known her, but I've heard this story in my family very often. And so her whole life, she was terrified by the idea that she would never see her children again in heaven, because they were not baptized and she was baptized. And so she would go to heaven and her kids would not. And so for her, it was a horrible suffering to never be able to see her children again, because they would be either in hell or in whatever, I don't know how you say it in English, the thing in between.
Limbo.
Or in the limbo, and that she would never see her children. And so my grandfather saw this, and so and the generations underneath, because she was not the only one thinking like that. Everyone was thinking those kind of things. And so the younger generations, where there was a scientific revolution and modernization of society, they were like, we don't want to suffer because how stupid is it to think that your child will never go to heaven because he was not baptized on time? So in the past, as soon as a child came out, we would baptize immediately because of this fear of. And so I think when it's driven by fear of all kinds of things, of hell, then at one point people start to, and it's really a pity, because I think there was also a very strong this religious practices. They really could help. The whole society would gather together for funerals, for weddings, for all those rituals that are needed to show the different stages of life and death. And that as a collective group, we come together and we grieve together and we do rituals together and do practices. Now it's all going away. I'm not criticizing people who are not getting married, but people are not getting married anymore. There is no first communion, no baptism, no. So, and then at the funeral, it's not happening in the church, so it's happening outside. And so it's just, we go there for a few hours and then it's finished. And so there is not this whole those whole collective gatherings at big events of life and death, and so society is crumbling apart. And we also see here, and I suppose in Bhutan must be kind of the same, you know, mental health practice, or just health practice. It started with the religious people. It was the nuns and the priests and the monks who started to take care of the sick, of the poor, of the mentally ill. Like recently, I visited a medieval hospital in Bruges, which dates from the 13th century, 12th century. It was founded, and they treated anyone who would come in, and they were nuns, and they would take care of anyone, of the poor, the sick, the mentally ill, and they devoted their life to take care of those people. And so it's really the church that has started all those things of taking care of the weakest people in society, and you know, and now that church is falling apart, all those institutions are being sold, and some of them are transformed into hospitals, but now they don't invest money in new hospitals. We are reducing the beds, and others are sold to create luxury apartments, and so our churches are even transformed into dancings, and so it's, you know, this whole structure that would keep the collective, you know, the whole society together is crumbling apart. And I think that's such a pity that is happening. And yeah, I think it's always about the middle way, right? I think in religious practice we really, there are really great things there that science doesn't have. Science is just observing what's happening and trying to look what is going on exactly, and how can we predict the future. If we know what's going on now, how can we predict the future? But it doesn't have the answers of, you know, human beings need to be together and need to be able to tell each other stories. And so by being together in this collectivity, we can carry difficult parts of our lives because we are not alone in this. And that's where religion and spiritual practice plays a big role, and also it gives meaning. And so what I see is, because of this spiritual void, people don't have, they are like, I'm useless, I'm sick, I'm useless, so I can better disappear because there's no life after death. And so, and I looked it up yesterday. Steve, I sent the article to Steve, but people with religious belief and religious practice are more protected against suicide attempts and suicide. And people who don't believe in anything, they are more at risk to commit suicide. So we really see that, so that religious, not just believing like I'm Christian, but that's it. It's really actively practice a religion and believing in what, really truly be a practitioner of your belief system that gives meaning to your life. And giving this meaning to your life will, they will feel suicidal too. It's not going to protect against suicidal thoughts, but they will not go into the act of committing suicide, because they'll be like, okay, if I have to go through this, that's because I'm being, you know, I have to go through this, I'm being tested. It's either my karma or it's God that's testing my, you know, God that's testing me, and I should go through this because God created my life and I have to respect it. And so it's, by having meaning in life, people will be less prone to commit suicide. I think, yeah, that's the best suicide prevention. So it's better than medication. So I think we should be more, we should try to find ways to have people find meaning again in their lives. I think that's a very big issue, and I think in Bhutan you are not there yet. And
we are, what we lack in science and technology and medications and things like that, we are compensated by so much of religiosity, spiritualism, and all the other things that we have. I, for one, I'm lucky because I'm only one player in my patient's life. I'm not pressurized to do anything miraculous for my patient, because I know there are many other players in his life, and yeah, the religious, the Buddhist monks, the shamans, the traditional healers, the Soa Rigpa, everybody is doing their bit, and I know I'm just doing my bit. And even if I do the whole lot, I still can't claim that I did the whole lot, because they always believe that somebody else did it for them. So I have to be humble enough to also accept that I'm just one part of the whole deal. I can also see that as societies advance, and as Dr. Caroline, you're saying, sometimes you can go, you might land up in the dead end, where all the belief systems go away, all the social structures are not there, and then sometimes the doctor is pressurized to really do something miraculous for the patient, because the patient has nowhere else to go to. But I am lucky, because my patient will always go to somebody. I don't have to tell him. He will always go somewhere, and he will always find something or other thing. I just have to be humble enough that I do my part. And if it helps the person, whoever, let anybody take the credit for making the person well. The job is I have to do my best, and then the patient gets well. That's it. But I can sense your frustration, because I can imagine that when the patients have lost a lot of those structures in a society, who otherwise would have helped him in some ways, I think the doctors are also pressurized to do something, which sometimes is not possible.
Yeah. Yes, there is a lot of pressure on us, because I think we have kind of replaced the priests in some way sometimes, although we are not trained as priests. But in Christian religion, one of the things is that you go to confession, and there was the secrecy of confession, and people would go there and talk about everything they had done wrong, and then they would be pardoned and still be able to go to heaven. And now there are no priests, and the people don't go to church anymore, and so the only place where you can go talk about your problems, and it's not going to be, there is this medical secrecy, and it's not going to be talked about to other people, it's the doctor. So we have kind of replaced that, the confessionist, the priest, and so people come to us, and for a long time I tried not to go too much into spiritual stuff, because I thought, I'm a doctor, I'm a scientist, and they should go see the priests, but they are no priests, and people don't know the priests if they are priests. And so now I just let them talk about their questions on the meaning of life, and is there a God, is there no God, and so now I do discuss that with them, because I know they have no other place to go and talk about it very often. Not everyone. People from different cultures, cultural backgrounds, lots of immigrants, they go to their imams or this and that, and so we try to collaborate as much as possible and stimulate them to go to see their imams, or if we see that it's going to be helpful for them. And as we know that, for example, people from different cultures, there is this idea that there is black magic that happens in the dark and alone, and then there is white magic that happens in a group, because it's transparent and everybody can be there, and the whole society can be there. So when people go to see to see a healer from more traditional cultures, I always stimulate that the mothers or the father or the family goes with them, that they don't go alone, to make it more, for them it's more important to be in a group and have witnesses of what's going on. So yeah, it's I think it's a fascinating subject and very complicated, and but very interesting, because we're talking about human beings and we are so different, all of us, and still have so much in common. That makes it fascinating. That's why I love to be a psychiatrist, because we work with human minds, and I think that makes us different from other medical specialists, because the only tool we have is dialogue. That's the only tool we have. We don't have blood tests, we don't have scanners and MRIs. Sometimes people ask me, why don't you prescribe me a scanner? I said, well, we do prescribe a scanner when there's first episode, to make sure there is no organic cause but afterwards, that's the only thing, it's to exclude organic causes, of that there are no tumors causing the symptoms or something. But after that, it's not necessary anymore. And so it's really investing in that tool of communication, but it's not only in psychiatric practice, it's all around us. When you want to, we really need to be able to have a good communication with people, and really understand and be able to, or first, as you were saying at the beginning of the dialogue, you were talking about other doctors doing diagnosis, but they had to redo it. I think, yes, it's really learning to listen to people, and really, really listen, and really try to put ourselves in their place and understand their world, and why they have certain behavior, and why they react in certain ways. And it's only then, when we can really truly listen, that we can start to make a correct diagnosis and understand them, and then also find tools to help them to find better ways to cope with what's going on for them, and the suffering that comes out of it.
Well, thank you both. This has been such a fascinating dialogue. I must say, it exceeded my already quite high expectations. So thank you to both of you.
Thank you.
I wonder if I might invite you both, if there's nothing, that's okay, if you have any final thoughts that you'd like to share as we come to the end of this dialogue. If there's nothing, that's all right, but perhaps there's something remaining on your mind that you'd like to offer as some sort of conclusion.
I would just like to thank you, Steve, for getting us together, and also for inviting me to your talk. I am so glad that I met Dr. Caroline and Camille from Brussels, and I'm able to have a very open discussion with them, a very frank, open discussion. Obviously, science and a lot of things have evolved so much in Europe, as we know. For Bhutan, we have just started on the journey towards science. So it is always helpful for me, people like me, to be in touch with people like Dr. Caroline, to know where they are going and how they have reached there, and what sort of issues and problems that they come across. And hopefully that we can learn from them, and also not make the same mistakes that they have gone through. So it is also very enriching for me as a mental professional to be in touch with people like Dr. Caroline, so that I know that there are people in the world who care, and who always be able to sort of give me some sort of nice talks whenever I might feel a bit burnout, or rather feel a little left out in some part of the world. So it's always good to chat with colleagues around the world. So this has been a fascinating discussion, and of course, we will not stop talking to each other beyond this podcast. I'm sure we will chat again on many, many matters that are of mutual interest to us. So thank you very much.
Yeah, thank you so much too, Chencho. I also wanted to say that I'm so impressed by your life story, and also by the fact that you were Bhutan's first psychiatrist, and that you had to do it all on your own, with no other mental health specialists other than psychiatrists too, no social workers, no nurses specialized in psychiatry, no psychologists. and doing it all on your own, whereas I was very, spoiled on that way. I've always worked in multidisciplinary teams, and it helps so much to have a team and to be able to think together and find solutions together for our patients, and being able to discuss it with other professionals with different views. That for me gives me a lot of energy. And so I can't imagine how I would have done it if it was all on my own. It's really impressive. I know how hard it is. Our job is really hard, but then doing it on your own, it makes it even harder. So I want to say how much I admire this, what you did until now, and how you could create from scratch the start of a mental health in your country. It's really, really, really amazing, and I think I also learn a lot from you. You have many things to teach me too. It's not only that I'm the specialist from the West. I'm not a specialist. I just have my experience, and you have your experience, and we can share things from our different experiences and make it useful for our patients, both of us, I think. And I'm so happy to have met you, that it was not just, watching you on television and say, oh, wow, what this guy is doing is great. I want to meet him. Well, then I did meet you. So it's really truly amazing. And I hope we can in the future continue. Well, I know we will, to continue to collaborate and to have discussions and share ideas, because it's so fruitful to every time we talk together. So yeah, and thank you, Steve, for organizing this dialogue. It's really, really wonderful. Thank you.
Dr. Chencho Dorji and Dr. Caroline Van Damme, thank you very much.
Thank you.
Yeah.
Thank you for listening to another Guru Viking podcast. For more interviews like these, as well as articles, videos, and guided meditations, visit www.guruviking.com.